Are you hearing me?
Yes,
Hello?
Doc. Afternoon, hearing you.
I'm about to share my screen so you can let me know if you're seeing it.
Yes, seeing it.
Okay, great. Um, so again, afternoon, everyone, and my sincerest apologies. It literally took me about an hour from Immaculate Gate to get to Manor Park. Very sorry, but we will jump into the meat of the matter nonetheless. So we're looking at respiratory diseases, which is an extremely broad topic, as you can imagine, because you have both non-communicable and communicable respiratory diseases. And so we're going to really focus on just our overall epidemiological and public health impact, and then look at a few conditions as we go along. This is an interactive session, so
In
at any
Spanish.
point,
St. John
hello?
is zero delta to the country.
First, your mic is on.
So at any point, please, if you have any questions or comments or suggestions, you can always contribute during the presentation itself. Okay. Um, hold a sec, hold a sec. Hold a sec for me, please. So why is it not moving? Oh, not today, not today, not today. Okay, so we're going to be looking at why respiratory diseases matter, what are some of the risk factors for the various respiratory diseases we see. And as I mentioned, we'll be looking at a few of some of the more prevalent ones, looking at the public health significance and public health prevention. So when we speak of respiratory diseases, we're looking at a group of diseases that not affect only the lungs. Some people think that it's only confined to the lungs, but we speak about the airways. And hundreds of millions of people worldwide have respiratory illnesses, many of which are preventable. And respiratory symptoms are some of the major causes of consultations at the primary health centers, the usual cough, colds, everybody complaining of having having the flu or having sinusitis. Many of these symptoms overlap, are not necessarily specific to any one respiratory condition, but it is some of the more common causes for persons to present to the health centers. So millions of people will have chronic conditions, like if we look at asthma and COPD, we know those who are very common. And this may lead to frequent hospitalizations, absenteeism from work and school, and reduced quality of life. So it is expensive. It is expensive, not just from the monetary factor of the cost of hospitalization, the cost of treatment in terms of medication and imaging, but also when you look at absenteeism from work and school. Absenteeism from school oftentimes means absenteeism from work for the parents or the caregivers. And for those persons who have chronic lung diseases, a reduced quality of life. Some of the chronic lung conditions that we have lead to persons having respiratory failure, which will impact how they go about their usual activities of daily living, now becoming dependent on oxygen, supplemental oxygen, which itself is quite expensive. And for these persons, sometimes they can't participate, they can't go to work, or they're limited in their activities. Diseases such as pneumonia, tuberculosis, and COVID-19 cause millions of deaths, so nothing to be scoffed at. The mortality rate for some of these conditions are quite high. And lower respiratory tract infections are consistently among the top 5 causes of death worldwide. Respiratory diseases respects no one. It affects persons of all ages and can be particularly fatal for young children, elderly, and those who are immunocompromised. And sometimes when we think about immunocompromised, we start to think automatically, in some cases, of persons living with HIV. But immunocompromised actually is a much broader, wider group, wider net than this, and it would include persons, for example, who have diabetes, some persons who are on some other what we call the immunomodulating drugs, and a lot of those are around now for treatment of certain autoimmune-related conditions, including asthma and COPD, and the various rheumatoid arthritis, for example, and those persons who may be on a steroid for a protracted period would all be considered immunocompromised, for example. I mentioned the economic burden, enormous healthcare costs and productivity losses, and is a financial strain not just on governments, but also on individuals and families. And then we have the global health threats. I mean, we all went through COVID and nobody would like to actually go through such an experience again. But we do have emerging respiratory infections such as novel influenza strains and the coronaviruses, and these pose ongoing threats, pandemic risks, and require global surveillance and preparedness for such. The reality, though, is that respiratory illnesses disproportionately affect lower and middle income countries, and these are the countries that can ill afford to have these conditions. So when we look at deaths, for example, COPD causes over 3 million deaths annually. Pneumonia kills one child every 39 seconds. And tuberculosis caused 1.3 million deaths in 2022. We have a slight reduction last year where it killed 1.2 million persons, but it's still a very deadly disease. And COVID-19, well, we had stopped counting the numbers, but since 2020, we know that more than 7 million persons have died worldwide. So lower respiratory infections are listed as the fourth leading cause of death worldwide. And so when we look at a rough classification, we can look at respiratory diseases either being acute, such as influenza, COVID-19, a hypersensitivity pneumonitis, for example, or then you have the chronic conditions which take their tolls, such as asthma, chronic obstructive lung disease or pulmonary disease, COPD, lung cancer, bronchiectasis, and pulmonary fibrosis. And what is of growing concern are the occupational diseases, including occupational asthma, asbestosis. Hold just a second for me, please. Don't hang up. Don't leave. Can I call you back in a lecture? All right, thanks. And then you have the smoking related illnesses. Other chronic respiratory diseases that were not listed there but are as important and not uncommon would be chronic pleural diseases, pulmonary eosinophilia, the rhinitis, rhinosinusitis, which is very prevalent, pulmonary hypertension, obstructive sleep apnea, which is estimated that approximately 30 to 40% of Jamaicans may actually have OSA or obstructive sleep apnea. So let us look at some of the causes and risk factors for respiratory diseases. Environmental factors are listed among the top causes for some of the respiratory conditions that we see. Air pollution, exposure to outdoor pollutants, as well as indoor pollutants can damage lung tissue and increase the risk of developing asthma, COPD, and even lung cancer. So as we have more industries, as we have more motor vehicles on the road, it is of concern with regards to the amount of pollutants that are there, the particulate matter. The smaller the matter, the more deleterious it is for the lungs and increased risk of developing lung disease. Air pollution for the past few years, every year, we see these large plumes of Sahara dust that come across. And we do know the concern is there for persons who already have underlying respiratory conditions, but even those who do not have may be at risk for developing such, depending on their other comorbidities. Tobacco smoke is a leading cause of COPD and lung cancer. And this, when we speak about tobacco smoke, we're not just speaking of active smoking, but we're also speaking of secondhand smoke exposure. And we now even speak of third-hand smoke exposure. I mentioned the occupational hazards, which are becoming of greater concern, both on the global and national level. And we're looking at workers who may be exposed to various dusts, such as coal, silica, chemicals, asbestos, not as common, but it is still around. And these fumes are at greater risk for developing diseases such as pneumoconiosis and occupational asthma. I will also like to list here persons, for example, who are in the hair industry. And we see it, salon owners and hairstylists and hairdressers who are using a lot of hairsprays, and many of which are heavily oil-based, and the increased risk of continuously inhaling these sprays and the effect it has on the lungs. Not just environmental agents, but we can look at infectious agents, including viruses, various bacteria. So we speak about the flu virus, but in recent times, RSV has been becoming even more prevalent. And then, as I mentioned, we have had the COVID-19 pandemic, but there are also other coronaviruses, which may cause acute infections and cause long-term effects, including long-term lung damage. Bacterial infections, you can have those related to acute pneumonias. Some of the more common ones would be like a strep pneumoniae or Haemophilus pneumoniae or Moxarella, but you have quite a lot. But not to be forgotten is the Mycobacterium tuberculosis, which can cause tuberculosis, which is a major global health threat. Oftentimes, we think not too much of fungi, but these are not to be forgotten, because we do have fungal infections, and we do have fungal infections affecting the lungs right here in Jamaica and the rest of the Caribbean. And we have to be mindful, particularly in our immunocompromised persons. When we look at genetic and biological factors which increase the risk of developing a respiratory disease, there may be a genetic predisposition, as we see in conditions such as cystic fibrosis, which may then cause an increased susceptibility to other conditions such as COPD. We know that asthma, as we sometimes say, run in families. So that is the genetic predisposition to developing the disease. And when we look at the individual themselves, we look at children and the elderly who are at an increased risk. Children, because they have immature developing lungs, and the elderly, because they now have weaker immune systems. You do have some conditions such as asthma, which tend to be more common in males, but the shift changes to females later in life. And then we also look at the immune status of the person, which would put them at risk. So we have quite a number of factors. We've looked at environmental, we've looked at some occupational, genetic, and now we have the socioeconomic factors. Poverty. So persons living in the lower socioeconomic bracket, persons in which you may have poor living conditions and overcrowding, with reduced access to healthcare, this increases the risk of exposure to infectious agents and reduces the ability to have these diseases treated effectively. Malnutrition weakens the immune system, making it harder to fight respiratory infections. And just to underscore, when we speak of malnutrition, we're not speaking only of persons who may be so underweight. We're speaking of poor nutrition. So we have to look at the nutrition content of the diets of which persons that persons are having. Nowadays, we have such a fast food fad that less persons are eating wholesome meals, such as those that would be rich in more vegetable and fruit. Not to mention that such foods also tend to be quite expensive. So if someone already is struggling to buy food, then it is always cheaper to be able to buy the low price carbs such as rice, margarine, etc., rather than going to buy fruits and vegetables. Limited access to health care. And access does not just mean the building and having doctors, but when we look at roads and roads conditions and the costs to get from one place to the next, it will impact someone's ability to access appropriate health care. Just to quickly look, lifestyle factors. A sedentary lifestyle reduces lung capacity, increases the risk of certain chronic diseases. A diet that is low in antioxidants may impair lung health, and substance abuse, including vaping, can directly damage lung tissue and cause the development of both acute and chronic conditions. Now, having had that overview, we're going to look at a few conditions. Are you still here with me and following along clearly?
Still here, still following. Yes,
Okay.
Doc, we're hearing you.
Thank you. So we're going to have a brief look at some conditions, and we're going to start with asthma. So it is estimated that asthma affects approximately 300 million people. And I would say that this estimate is an underestimate of the true numbers because we're not required to send in notifications about the diagnosis of asthma. Many persons also believe that you have to be wheezing to have asthma, and this is not the case. And many times asthma goes unrecognized or wrong diagnosis is given. So I still see patients who, when you ask them about any childhood history of asthma or any childhood history of any respiratory conditions, they may say, no, doc, I only had bronchitis. Okay, how many times you had bronchitis? I've had bronchitis frequently, many times, nearly every year. And we know that the average person does not have repeated bouts of bronchitis, and it is likely that the person indeed had asthma, which was misdiagnosed. It is estimated 1 in 12 people in the world have asthma. It is more common in children, often diagnosed in early childhood. However, for the very first time, someone can develop asthma during adulthood. We see it more often in women, but it can occur. And as I said, the person does not necessarily have to be wheezing to have the diagnosis of asthma. The prevalence varies widely, but it is by country and region, and it may be seen sometimes in more developed countries, and this may be due to urbanization, air pollution, and other environmental factors. That being said, low-income countries are seeing rising rates as they too undergo urbanization and increased exposure to pollutants. So it's the most common chronic disease of children. Its prevalence is increasing. The estimates for adults is anywhere from 10 to 30%, with a global prevalence being about 80% of the population. One of the struggles with asthma is the diagnosis of it, because there was a time when the various authorities on asthma would say that you need to have spirometry, lung function testing to accurately diagnose asthma. But we know that many countries, including Jamaica, they don't have widespread access even to spirometry. So we need to really look at how the diagnosis is made. And this accounts for the widespread we see between 10 to 30%, because a number of the surveys have used different methods for diagnosing asthma. So does asthma kill? Yes, it still kills, right? The number of cases of asthma has significantly increased in the last 25 years. However, deaths have been constantly declining as a lot of research and medication availability has come about for asthma. The incidence peaks just before age 5, and mortality we see increasing with aging and reaching the peak after 80 years. Because you tend to have more women than men, there is the economic burden and mortality is seen higher in women compared to men. So there may be genetic factors behind the development of asthma, more common among those with a family history of allergies or asthma itself. So I'll often ask a patient, do you have anyone in your family that has asthma? Do you have anyone in your family that has allergies, and particularly the rhinitis or rhinosinusitis? If you ask the average patient about rhinitis, they may not understand the terminology. Many of them will say, Doc, I have sinus problems, most of which tend to be rhinitis, but you do have rhinosinusitis that may be associated with asthma itself. Then there's environmental exposure, air pollution, and secondhand smoke, for example, are all linked to the development of asthma in children. And the exposure to environmental toxins are major contributors to the exacerbation of asthma. So when we have that Riverton City fire, and I can stay all the way in Ligony and see the smoke from Riverton City, I know we're going to have more patients coming in with an acute exacerbation of their asthma or COPD or acute and chronic worsening of their underlying respiratory disease. Respiratory infections, repeated infections in early childhood increases the risk. Lifestyle factors, we mentioned exposure to tobacco smoke, but lack of physical activity and obesity have all been linked to an increased risk of asthma, or in persons who have asthma, worsening of symptoms. So here it is that I have had parents who have called me about a child or their child who has asthma and would like me to write an excuse for that child not to participate in phys ed at school. And I'm not writing it, because we all should be exercising, including children. We may have to modify the exercise while we work to get the asthma under control. But the lack of exercise itself is a risk factor for many conditions, and it is a risk factor for worsening lung function and increased risk of exacerbations. Occupational exposure. So you have persons who will insist that they've never had asthma before, and it is after working in certain environments that they have developed asthma. It can be a little tricky sometimes to diagnose, but we do know, even though in those persons who may have an increased risk of developing asthma under the exposure to certain environmental and occupational factors, it may then unmask the asthma. The costs are substantial, and we mentioned some of these before. And the medication, let's give thanks for here in Jamaica, we do have the NHF that has provided assistance for many chronic conditions, including asthma, but the medications are not cheap. You have an asthma inhaler right now that can cost $30,000 per month. And this is not the first line therapy. So that person would be on other inhalers plus asthma And many of these persons have other comorbidities that require treatment. So we have to pay attention to the cost because it is quite substantial. I mentioned the hospital admissions are among some of the more, asthma exacerbations are some of the more common reasons for persons to seek medical attention, and asthma-related emergency hospitalizations are not uncommon. I had mentioned, however, that because of we oftentimes will say someone with asthma may have a cough, shortness of breath, chest discomfort, a wheeze, but a person does not necessarily have to have all of these symptoms to have the diagnosis of asthma. And part of that contributes to the underdiagnosis as well as the unavailability of some of the testing, the spirometry testing, which globally is used to confirm the diagnosis of asthma, or lung function test. I will skip over this slide because Morales had made mention of it before. Just to look at 50% of persons with asthma have symptoms daily, but many of these persons will actually deny it because they become so used to becoming short of breath. Or I have a patient who says, Doc, once I get downstairs in the day, I don't go back upstairs unless I absolutely have to, because they're going to become short of breath. So they adjust their lifestyle to compensate for the shortness of breath that many of them may have. So the interesting thing is that mortality does not necessarily correlate with the prevalence. And a lot of this just boils down to economics. So the countries that will have a higher prevalence of asthma are those countries that are urbanized and have larger industries. But these are the countries too that can afford the medication required to treat asthma. So there are the debilitating daily symptoms for some persons, limitation of activity, repeated hospitalizations, and the risk of disability and death. So when we look at prevention and control, we have to look at the various risk factors that are there and address them. So reducing exposure to allergens and pollutants and tobacco smoke, to public health policies such as smoking bans, but not just to say we have a ban, but we need to enforce the ban. And we need to educate persons on the reasons why it is important for these lifestyle modifications. And the education not just starts at adulthood, but within the primary level of schools as well. Lifestyle changes can reduce the risk of asthma and an exacerbation of asthma. We need to educate persons about the importance of being adherent to treatment protocols, using medication as is required, and having the appropriate medication prescribed is also very important. Persons should have an asthma action plan. A patient should feel empowered on how to manage their asthma. And as I mentioned, health education is very important, and we need to start looking at screening and early detection. Disparities do exist in asthma management. Non-Hispanic Black people have an asthma prevalence 30% higher than non-Hispanic Caucasians. The emergency department rate is much higher for Black persons. This is information coming out of CDC, and non-Hispanic Black people are more likely to die from asthma, with an asthma death rate at times being over 200% higher than Caucasians and 160% higher than Hispanics. So obviously there's a lot of work that needs to be done, and a lot of work needs to look at the reasons for the disparity in these countries and how to go about fixing it. This is just looking at some of the inequalities. Hello?
Yes, sir. I was just asking you to go back to that slide for just a second. I just wanted to see something quickly.
This one?
Yes, sir. Oh, okay. Never mind. You can go. I thought I read something wrong. It said non-Hispanic white people. That's
Yes.
okay. You can go on. Thank you.
Okay. So we look at disparities, lower socioeconomic urban neighborhoods, lower socioeconomic status, and of course, children within these communities being at greater risk. So you have the racial and socioeconomic inequalities, and even there are the global disparities that exist in terms of how asthma is seen and managed. So asthma is a major public health issue, significantly impacts on individuals' health, quality of life, economic productivity, and mortality. And we need to really look at the causes for the disparities, and greater public health efforts need to be addressed, looking at prevention, early diagnosis, and available, accessible, affordable management. Thus, and also looking at reducing environmental risks. So we will move on from asthma to chronic obstructive lung disease or chronic obstructive pulmonary disease, which, while asthma is a disease that affects the lungs, the airways, COPD actually is thought to be a more heterogeneous disease affecting a number of organ systems, of which the lung is the primary system that is being affected. 2023, about 251 million people, so nothing to be scoffed at. This is a disease primarily of adults and is the third leading cause of death worldwide. Prevalence, again, varies by region, where higher rates are seen in areas with significant exposure to smoking, air pollution, and occupational hazards. And low and middle income countries, somewhat similar to asthma, are facing increasing higher rates of COPD due to increasing tobacco use in some countries and air pollution in the so-called urbanized areas. Smoking is a leading risk cause for COPD and is responsible for about 85 to 90% of cases in developed countries, and both active and secondhand smoke exposure contribute significantly. So you will hear someone says, no, doctor, my son don't smoke when inside the house, they smoke outside, but yet the risk factor is there because there is still secondhand smoke taking place. Air pollution, long-term exposure to both indoor and outdoor air pollution, including fine particulate matter, is a major environmental risk factor for COPD. There are occupational risk factors as well, genetic risk factors, the alpha-1 antitrypsin deficiency. We do see in a handful of patients. We don't have that many persons in Jamaica, but I suspect while our numbers may not be high, it is likely higher than what we even think, just because we're not looking for it, and it is difficult for us to assess for alpha-1 antitrypsin deficiency here. Recurrent respiratory infections during childhood, can also increase the susceptibility to COPD in later life. We look at what they call a multi-hit hypothesis for COPD, that someone who may have a number of these risk factors put together is an exponential increase in the risk for developing COPD. So you may have tobacco smoke, then the person may have had other comorbidities, they may be exposed to outdoor air pollution, there may be a female and may have been born prematurely. So you have a number of factors coming in that would increase the risk of developing COPD. The reality is that most of the information we have on many diseases, including COPD, come from high-income countries, and this data underestimates the total burden of COPD. Another concerning area is that the definition sometimes varies between the various studies that they are out there. So we need to actually have an approach using a single term and a single diagnostic definition for COPD. So COPD is generally higher than is recognized, and it is estimated to range anywhere from 4 to 20% in adults over the age of 40, many of whom are now in their productive years, and the numbers are considerably higher in smokers. There's a large difference between countries, and this may be due to, as I mentioned, differences in diagnostic methods, the year of study, the age of the population that is being looked at, and the prevalence of risk factors such as tobacco smoking. So countries in which tobacco smoking is relatively low will have lower numbers, say, for example, countries that have a high prevalence of tobacco smoking. And this is seen when you look at countries such as the US, where in 2002, it was estimated that 24 million persons, right? In the Asian countries, looking at 12 countries, it was about 56 million with an overall prevalence of 6.3. In India, the prevalence is about 7%. So this 7% of the population is a high prevalence of persons having COPD. So the numbers are not known. What is of concern is that number of smokers are increasing among the young, particularly young women, and we don't routinely screen for COPD. And as such, diagnosis is then often made when the person is symptomatic, having had now been diagnosed with moderate or severe disease. It is also very expensive to treat. The drugs used for COPD, and I should even go back to asthma, they are nothing to be scoffed at. So someone could easily be spending $50,000, $60,000, $70,000 a month for some of these drugs. And then we all know, we recognize the biologics. The biologics themselves are injectables, which work based on an immune basis. And these drugs cost anywhere from $2,000 to $4,500 US every 4 to 6 weeks. So they are expensive. Hospitalization and emergency visits. Many persons with moderate to severe COPD will have exacerbations requiring hospitalization. And with this, their underlying lung condition will sometimes worsen. And then there's a chronic care. So unlike a pneumonia or even an exacerbation of asthma, once these persons improve, they're usually much better. A person with COPD, we can't cure, and as well as it's a continuous downhill spiral in their basic day-to-day living and their respiratory lung function. So there comes a time when such persons will require additional assistance and chronic care needs. So when we look at some of the occupational risk here in Jamaica, we look at our mining, we look at the cement factory and the flour mills and the construction industry, where, I mean, right now in Jamaica, every other corner has some building going up, and you're not seeing persons wearing the appropriate protective equipment. Indoor pollution, I did mention, for example, the Riverton City fire dumps, the increasing number of vehicles on the road and the vehicle emissions. This, in some communities, the burning of garbage and bush is so commonplace it has become a norm, but it does increase the risk of underlying respiratory diseases. So the under-recognition and under-diagnosis leads to under-reporting, and under-reporting leads to reduced awareness and understanding. So we need to have additional sources of sampling and availability and accessibility to spirometry, which is used to make a definitive diagnosis of COPD. Here in Jamaica a few years ago, we actually participated in the BOLD study. which was to look at the prevalence and burden of COPD across a number of countries across the world. And our BOLD study, interestingly, it was published a few years ago. It has not been widely circulated, but we did have a few hiccups with it, looking primarily at COPD, looking at spirometry, and the use of spirometry for diagnosing the patients. And our prevalence rates among persons with smokers, interestingly, were a little lower than what we anticipated it to be. I need to see if I can find the data of BOLD, Jamaica, and share it with you. So as I mentioned, COPD is thought to be a heterogeneous disease affecting not just the lungs, but you do have other systems that are impacted. And you do have associated comorbidities with COPD. Persons with COPD are at an increased risk of having an MI, angina, heart failure, increased risk of osteoporosis and other endocrinopathies such as diabetes and hypogonadism. They're at risk of having lung cancer and recurrent respiratory infections. We see depression in many of these patients, not just because they now have this debilitating disorder, but if you even take away that factor, that we do see an increased number of depression in these persons. Weight loss and their inability to maintain their weight is also seen in some persons with COPD. So there are the debilitating symptoms, and as I said, it's a downward spiral, resulting in limitation of activity, absenteeism from work, repeated hospitalizations, severe disability, and premature death. So it is an economic burden to both patients and caregivers and the time that it takes. So looking at prevention and control strategies, we need to be more stringent in our tobacco control and our anti-smoking campaigns, looking at tobacco taxes. Someone asked me if tobacco taxation really works. Interestingly, it has been shown that tobacco taxation, increasing taxes on tobacco, really deters persons from smoking. Air quality improvement, and including both indoor and outdoor air pollution. We need to take this in hand because if these are improved, then this can significantly reduce COPD risk. So while we look at the number of vehicles coming in and everybody wants a car, we need to be able to remove such emissions effectively from the environment. We need to do something about Riverton City and the frequency of fires, and also look and be able to better prepare our persons for when, for example, the Sahara dust is coming across. And then in the workplace, we need to pay particular attention, again, to the appropriate protective gear being provided for workers, and not just being provided, but also being worn by the employees. Early diagnosis and screening through spirometry and screening programs, if accessible, can identify COPD in the early stages. And while we cannot cure COPD, and we do know it's a progressive disease, we do have medication to try to slow the progression of such. The number one method of slowing COPD is tobacco cessation. Stop smoking. Yes. Vaccination and infection prevention is also very important. I know that since COVID-19, vaccines in adults in particular have gotten such a beating, but we need to really look at the science, look at the efficacy of it. Remember that no vaccine gives 100% guarantee of preventing an infection. Yes, we're hoping that we can prevent, but we're also hoping that if somebody is exposed and develops an infection, that it reduces the severity of such. And these persons already have compromised lung function, and recurrent infections just makes it worse. pulmonary rehab programs. So these are structured programs we need to have made available. And I remember where I trained overseas, you actually had in hospital rehab programs. So these persons would be admitted for about 6 weeks for rehab during which time select specific exercises would be given to them, right? But it doesn't have to be an in-hospital admission. You also pulmonary rehab as an outpatient is important. And for persons, let me just message a hospital. Sorry. So for persons who cannot attend rehab, or where rehab is not available, for healthcare workers who manage patients with COPD, we need to advise them to exercise. Now, we're not telling them to go take on a Usain Bolt or to go run around a ring road or to go walking miles. It may be suited to what the person is able to do. If it is that they can sit in a chair and do leg raises or marching or using light weights or just using their own body as weights, we need to be able to advise them. If they have, a veranda or around their home and can walk, because exercise is important for these persons. There again are disparities in management, somewhat similar to what we've seen with asthma. Again, it is often underdiagnosed and undertreated in the low income and middle income countries that have limited access to healthcare and diagnostic tools and the medications. And as such, people from these groups, from these backgrounds, and the so-called minority groups, and in rural areas may face greater barriers to accessing care, leading to worse outcomes. I also say that as healthcare professionals, we need to lobby for our patients and be able to lobby the various authorities for our patients and assist in terms of the accessibility and availability as much as we can to medication. Sorry, I have a patient in trouble. Okay. So in concluding, leading cause of death and disability globally, it leads to significant economic and personal consequences, and we have to look at prevention because in most cases, COPD is preventable. Moving on to lung cancer.
Just before you move on, just to clarify, you said in terms of access to medication, you're saying healthcare workers, we should lobby more in terms of access. In terms of like having more drugs on NHF for them, or
so it is going to be also relevant to where we are in terms of where we work. So I will give you an example. I am at National Chest Hospital, and when I first got there, we know that we use inhaled steroids for a lot of our patients, and a lot of patients were getting just inhaled steroids, but at doses that were inadequate for the bulk of our patients. So I'm not knocking any one drug, but a very common one would have been Becotide at 50 micrograms. And the patient is told, take 5 puffs 2 times or 3 times daily. Patient's not going to be adherent or compliant with that. And many persons can't even use an inhaler appropriately. And yet the guidelines will say that such an inhaler may be appropriate just for the first step or the second step. So what happened to the second, third, to the 5th step? So now we're talking about combination drugs. So you have to lobby, when I say you, I mean generally speaking. and this is what we did actually, lobbied. We wrote letters to say why it is we need the medication that the patient requires and the savings that can come about. So you have to have the data behind you, and also not just local data, which may be difficult to get, but international data. So we can't just sit down and say, okay, well, the government gives us Becotide, this is all we're going to use. Because with due respect to some of our persons within the NHF, for one, they may not know. They may jolly well not know what is going on. I mean, the NHF has made leaps and bounds over the past few years. Not few years, over the past years. And they really have taken on a number of things, and they have really made more and more accessible and available. But we, as the healthcare providers, should provide some sort of guidance to the NHF. We should be providing guidance to the formularies within our pharmacies or our healthcare centers. We used to purchase at National Chest Hospital. I'd have to write a letter nearly every 2 months why the hospital must be spending so much money to purchase a particular drug until it eventually came on the pharmacy formulary. You will hear also that, oh, certain hospitals, because they are the so-called specialist hospitals, they get certain drugs. But the reality is that the bulk of patients, say for example, with asthma, are not being seen at National Chest Hospital. They're being seen in the health centers. They're being seen at other institutions and in the private doctors' offices. So going back to government hospitals, though, so some hospitals may not have some inhalers, while another hospital has, which therefore I'm saying for those who don't have, and yes, it is on the formulary, and they're treating patients, we need to start to lobby, say, well, our patients need it too. So that's what I mean about lobbying.
Okay,
well, not to pick up placards. Yes.
Excuse me, Dr. Baker, I had my hand up.
Oh, sorry. I just
I
seeing
wanted
it.
to. Yes.
Yes, sorry about it. Just seeing it.
All right. I wanted to have an idea of what you think a rehabilitation program within the community or within health centers could look like for COPD.
So,
or lung disease in general, because I know it's not just COPD.
Right.
Persons with COPD would benefit, but other persons.
So that's an excellent question, Nicole. So in terms of health centers or within the communities, ideally you should be working with, say, a physiotherapist if you have access to such, right? So it may be that you have a program through a health center where if a physiotherapist could come in, or you have somebody who is then trained. And what it is, for example, some of my patients who I see in office, I will ask them about their home. And you set targets for these persons, right? You set targets in the sense that we're going to aim at first, maybe the person can only do 15, 20 minutes. So if it is somebody who can walk, even with a walker or a cane, so you have to set targets if it is that the person is going to be at home, because many of the community health centers may not have access to space to say to bring someone in for them. But it means it is sometimes it's breathing exercises. So I do that as well. Teach my patients breathing exercises and breathing and devices that they can use. And I may say to them, I need you to try to give me anywhere from about, I'll individualize it, 7 to 10 breaths, 2-3 times a day, 4 or 5 times a week, right? Oh, Dr. But I say, yeah, while you sit down watching news, you can do it. We're going to get up and we're going to move. You know, just saying, get moving our Jamaica move, but we need our COPD patients to move. So if it is that they can walk, and this is now time dedicated to walking, I've had patients who say, okay, they have a veranda, so we're going to go back and forth. Or their yard is sufficiently safe, they can do it. Or they may have a driveway that they can do it. So we need to identify various exercise activities that can be done. We can lean on, as I mentioned, our physiotherapists from other institutions to assist us. So you also have weights. Just last week I was telling a person, at first just use your own arms, So let's go raise your arms. If you can go shoulder length, fine, and just circles, or we're going to go above the head. And if we're going to go above the head, we're going to go up and down, see if we can do 5, 10, 10 reps. If we can do more, 3 times. And when I see the patient, I then assess what it is you're doing and what it is you can manage. Can we go more? Do we have to stay at the same level, or do we have to go less? So it is a number of different things. For persons who have access to swimming pools, it may mean going into the pool and even trying to walk around. So you have to really individualize the exercises if it is that you don't have programs out like at a hospital or nearby. In terms of if you want to develop something within a community at the health center, it is maybe inviting, having someone come in twice a week to do programs with your patients who have underlying respiratory diseases. But it does require individualized attention because not everyone is going to be on the same level. So it's not like can have an exercise class. It's actually individualized attention. I don't know if that even brushes what you've asked.
Yes, in a sense it did in terms of the guidance that I can give as a physician, but also when we look at, we're speaking about lobbying for care, so that it means that as we lobby, because there are other patients, for me, who in primary care, for example, patients who've had a stroke, who really would benefit from physiotherapy. But I wanted to know, even as we're lobbying, is not just a stroke patient, but now we're talking about those with respiratory illnesses and how incorporation of physiotherapy can be something we'll look at in primary care, because it's going to be easier for the patient to get it within their community than to say go to KPH. And I know the hospital physiotherapy units are
just
overwhelmed,
burdened.
Yes.
So
they are overwhelmed. But that's an excellent thought process. But it also highlights the disparities that we have even within here in Jamaica. And some of it too is just an economic burden. I'm going to get very personal here. I had to have surgery some years ago, right? And after surgery, I required long-term physiotherapy. And through insurance, etc., I was able to afford to have physiotherapy. And then there was another person that I knew of who had similar surgery. And they went their hospital physiotherapy department gave the person a 3-month appointment to come for physiotherapy. Or some months, might not have been 3, but like 2 months to come for physiotherapy. There's no way that after surgery, even if the person that you're going to get a physiotherapy, that is going to be effective after so long. And, she had reached out and said, well, I'm not doing it through the hospital, I'm doing it privately. But I say this to say that she never had insurance, and she had a few private sessions, but not what was required. So the fact that she had surgery and fixed, in quotation, the problem, it never really impacted her life that much, because she still required a lot more of attention. And so when we lobby, there are different levels of lobbying. So okay, fine, you jump up and say, okay, yeah, great, we can get the surgery done. But what happens, because it's supposed to be a package. And likewise, like even for our respiratory patients and our stroke patients, it's the fact that the person's blood pressure is now controlled and they can come up. What about the physiotherapy? And not just physio. Occupational therapy is also very important, and this is where we may have to start small So we can't take on everything all at once. So I applaud you for looking at the health sector. Maybe we start with one thing. Maybe we start with stroke patient, or maybe we start with a COPD patient, and from there it will grow. But also to be able to empower persons to go home and do it. So whether we need to look at printed material for persons to do, but we also, when the person comes back, we have checks for them. I see a hand as well. Alex Lawson.
Hi, good evening. So I'm a physiotherapist, and I just wanted to add in regards to the whole conversation as it pertains to community-based rehabilitation. So we are in the process of operationalizing in our profession what we have as level 3 physiotherapists who are community-based physiotherapists. That would be essentially in our health centers. However, as with anything in the country, it takes time to actually get these posts operationalized and functional that we can have the impact. So the aim is to upload hospital-based physiotherapy departments for conditions such as COPD and CVAs, which require more community-based care so that we can diversify and reach a greater audience. We mentioned about the long wait times. It is a harsh reality. 3 months sounds about appropriate in the public sector to get an appointment, regardless of the condition. You might be lucky to get a 2-month appointment, but that's where things are in the public sector as it regards to appointments. And then doubling back down on the COPD-based rehabilitation. So the gold standard of care is that for every person that's diagnosed, and I'm sure Dr. Baker, as a pulmonologist, that they should be integrated in some form of community-based rehab program, to optimize outcomes and work closely with the pulmonologists to rehabilitate, which you'd have already touched on in that regard.
Well, thank you, Alex. I really welcome that news. Yes, we know things take time, but that is certainly welcome news. And this is where too some of even the lobbying can come on, because we don't let the ball drop. The frustration will come on, but somebody has to keep on pressing on and pressuring for it to become a reality. Alex, your hand is up again.
No, Doctor, I just lowered it.
Akeem, you're gone?
Yes, Doc. Everything I was gonna say has been said, so yes,
Okay.
thank you.
All right. Well, thank you for that, and I really welcome that discussion, the community-based, and the thought process that yes, our health centers should function more than just coming in and getting vaccines and maternal health and or daily follow-ups, because we need to have other areas of care if we're really thinking about care of our patients. Thank you. So we're going to look at lung cancer next. So it's the second most common cancer in both men and women. This is internationally. This is not for Jamaica, right? In Jamaica, we still have breast cancer as number 1, colon cancer, and as well as cervical cancers as the more prevalent cancers. It's a leading cause of cancer deaths worldwide. And worldwide, this may be outdated data, but it's just to show you that we had about 1.7 million deaths occurring. So it's the number 1 cause of cancer-related deaths, accounting for about 1.7, 1.8. Globally, about 2.9 million cases are diagnosed each year. And the rates of lung cancer are higher in countries with high smoking rates. Again, why we need to be serious about tobacco control, but not just smoking. Air pollution is also important, and we also have genetic factors. Most people diagnosed with lung cancer, we're talking primary lung cancer, we're not talking about cancer that has spread to the lungs, are age 65 or older. That being said, my youngest patient with lung cancer was 21 years old. So that of course is not common, and you'd have to look at some of the other factors. But for that 21-year-old young man, he was smoking from he was 10. Right? So he already had a significant smoking history. The incidence has plateaued in men, but interestingly, it is increasing in women. Women have fought for equality in so many things, now they're fighting as well in the wrong area in terms of cancer diagnosis. Again, there is racial disparity when Black men are 20% more likely to develop lung cancer. However, the rate tends to be lower in Black women compared to white. So smoking is the biggest single risk factor. And worldwide, smoking accounts for about 80% of the cases in men and 50% in women. If someone has been diagnosed as having squamous cell and small cell carcinoma of the lung, many of these persons were smokers or previous smokers. So we're seeing a shift from squamous cell lung cancer to adenocarcinoma. The adenocarcinoma, yes, you can get it in smokers, but this too is a cancer that we oftentimes see in persons who have other risk factors for developing lung cancer. So other risk factors, COPD, many of these persons are smokers, but there's a family history, secondhand tobacco smoke, the indoor fumes, and then the occupational exposures, such as asbestos, chromium, and coal tar. So these are some of the risk factors listed here. I have included HIV, because there was a time when HIV infection was associated with an increased risk of having lung cancer. And there was a lot of debate taking place as to why the numbers seemingly was higher the numbers were higher in persons living with HIV, whether it is that such persons may smoke more, whether it is that there was once thought that some of the therapy used to treat HIV may actually affect the oncogenes that impact the development of lung cancer. I don't think they have fully explained why it is so, but we do recognize that there may be an increased risk with persons living with HIV. So the lung cancer is the #1 leading cause of cancer death internationally, but it is the most preventable death than any other cancer. And this is because of the association with smoking, particularly cigarette smoking. There has been a gradual change in the way cigarettes have been manufactured, which has resulted in a shift of the histology as well from the squamous cell and small cell to more adenocarcinoma subtypes. So here is that we look at the relative risk of smoking, which is tied as well to the number of cigarettes per day. And we see that there is a significant rise, particularly in terms of the years of smoking for all categories, whether it is less than 10 to 19, or more than 20 cigarettes per day after having about a 40-year pack history. So we speak of a pack history. A pack year is someone who has been smoking 20 cigarettes, assuming that 20 cigarettes are in the pack, 20 cigarettes per day for for each year. So that's how we calculate the years of smoking, or pack years, as we refer to it. The survival rate tends to be low. It's approximately 20.5% globally, and I will say even less for those persons who have been diagnosed as having lung cancer in Jamaica. This is largely due to late-stage diagnosis, making it one of the most difficult cancers to treat. So because we have so much lung tissue, and the lungs can remain relatively asymptomatic unless you have breach of an airway, or the lining of the lung, or the pleura, as it is known, is affected, then cancer cells can stay there and multiply within the parenchyma until they either cause some level of obstruction within the airway, or affect the pleura, or cause some amount of hormonal changes or other signs that are not necessarily related to the direct presence of the cancer. So they can stay there for quite a while, multiplying and not cause any issue. And unlike breast cancer and cervical cancer, again, we're not screening for lung cancer, even though there are screening regimens that have been recommended. Survival by stage 1 has an approximately 50% survival rate, and stage 4 a less than 5% survival rate, and this is the 5-year we're speaking of, and the median survival is that of 6 to 12 months, underscoring the real need for us to look at screening in the appropriate persons. Smoking cessation programs, when we look at prevention, these are aimed at reducing smoking and have been shown to actually reduce lung cancer rates. So when we look at taxes, advertising bans, warning labels, but the law needs teeth behind it. Does it make sense? We have a law and it's not being enforced. Public education from babes right up is important, and these that promote what the risks of smoking are, the benefits of quitting, and the dangers associated not just with active smoking, but secondhand smoking, have been shown to reduce the incidence of lung cancer. Screening and early detection I made reference to. Screening with low-dose CT scans is recommended for high-risk individuals. Now, not all CT machines can do low-dose CT. A few can, but we need to really start to look at this area, and for patients who may be at risk, to investigate where it is that they can access such scans. While it is that cigarette smoking is the #1 risk, we also have to look at the environmental risk factors and looking at air quality improvement. That was it in a, cigarette smoking causes more than 480 deaths each year in the US alone, and combined, you have more persons dying from cigarette than HIV, illegal drug use, MBAs, and firearm-related incidents. This is internationally. In 2000, 1.2 billion people smoked, and the numbers in kids are rising daily. Interestingly, developed countries, the rates are decreasing, while in developing countries, it is increasing. But while it is declining in developed countries, what is definitely rising is vaping. And vaping is not benign, it's not innocuous, it is associated with risks as well as significant respiratory risks. Where am I? So this was coming out of the Jamaica, I think there's a more recent one I need to get out to you. Basically, the Jamaica Lifestyle Survey, which showed that 1/3 of students at the time used any form of tobacco. 20% of those surveyed, this was age 13 up, were smoking cigarettes. Others were using other tobacco products. And 4 out of 10 persons lived in homes where other persons smoked, and 6 to 10 are exposed to smoke in public spaces. So these increases their risk of smoking, their risk of lung cancer, but their risk as well of other respiratory illnesses such as asthma. So when we look at a cigarette, it really makes me wonder why would someone smoke? There are over 599 additives in the smoke itself, and at least 60% are carcinogens. And I don't gamble, but I would gamble on a cigarette because it is one of the few products that, if used as it was intended, not that you are overusing it, use it as intended, it will cause harm and kill. These are some of the chemicals seen in cigarettes, right? And I mean, why would you want tar and formaldehyde down in your lungs? Everybody going green nowadays. They don't want to take Panadol. Everybody drinking whatever, guinea hen, name it. It is out there, soursop leaf, and yet put a cigarette in the mouth that has all of this. It just does not make sense. But the thing about it is that it is highly addictive. Cigarette smoking is highly addictive. It is more addictive than cocaine. And when I say addicted, I mean a true addiction where receptors within the brain are affected, and the person who smokes will oftentimes have the urge that they need to go back. I have patients who have had heart attacks and stents, and who have underlying COPD and heart disease, and who continue to smoke. I have patients who have had lung cysts and, have what we call it ruptures and has a pneumothorax, end up in hospital with chest tube. They're smoking before all of that, and they're still smoking. And you have patients, quite a number of patients who smoke and who have asthma. Smoking is not just associated with the developing of lung cancer, but increases the risk of coronary heart disease 2 to 4 times, stroke up to 4 times, women developing lung cancer 13 times than compared to the rest of the population, and in men 23 times. And dying from COPD, smoking increases the risk by 12 to 13 times. So the story here is, if you don't smoke, don't start. And if you do smoke, it's time to get help to stop. There are other cancers associated with cigarette smoking: bladder, leukemias, cervical cancer, cancer of the larynx, of the esophagus, breast cancer, stomach cancer, name it, pancreatic cancer. So it really should be legal altogether. And when the person smokes, it's not just years to develop cancer, but from the first smoke, from the first cigarette, from the first inhalation, we start to see negative impacts. And the persons who smoke will often tell you that they cough up more, there's increased mucus production, their whole ciliary action, which helps to clear the airway, is impacted. There is destruction of the airway over time, and a chronic inflammatory process is set up, which loans itself to developing chronic bronchitis, emphysema, COPD, and increased risk of lung cancer. Other respiratory diseases, and some of these are seen in persons with secondhand smoke: recurrent sinus infections, recurrent ear infections, recurrent pneumonias, particularly in those with secondhand smoke as well. Smokers may have a smoker's cough. They too are at risk of pneumonia, an increased risk of tuberculosis, and having interstitial pneumonia, pulmonary fibrosis, and respiratory failure. Pulmonary embolism is also seen in persons who smoke at a higher incidence. So that is it in a nutshell for lung cancer and smoking. We're going to look at occupational lung diseases. So these are a group of diseases that are caused directly by harmful substances in the workplace and may include dust, chemicals, and biological agents. And this would include like coal workers, pneumoconiosis or black lung disease. If you ever see a post-mortem of someone who smokes or who has worked, who works with coal, you don't even have to go to postmortem. If not bronchoscopy, I have looked down in the lungs of persons and it is literally stained with tar. Can have silicosis, asbestosis, hypersensitivity pneumonitis, which we can see, for example, in persons, as I mentioned, the persons in hair salons, the hairstylists, barbers, those who are raising birds, various birds, and doing chickens, raising chickens. The diseases are often chronic, progressive, and unfortunately irreversible. And because of it is related to jobs and environment, you have millions of persons who are at risk. Approximately 15% and up to 20% of adult asthma cases are attributed to actually occupational exposures. And underreporting is prevalent. They are often heavily underdiagnosed and underreported. And we could stay here and argue why, but it often makes the estimation of the burden difficult, and the numbers are greater than the official figures suggest. So how to recognize and establish, we need to be aware, suspect, look at occupational history. We need to get the medical history of the persons that suggest it may be actually related to work. Is it that they are sick in the initial stages when they are at work, and when they go home or no longer in the environment, they tend to be better? Did the symptoms start before or after employment? And you do have persons who will seek legal recourse, having developed what they think or they believe are occupational related respiratory diseases, but yet when you look at it, these persons may actually have had respiratory illnesses before. There therefore needs to be objective testing to establish that these persons do indeed have occupational related respiratory diseases. And I have seen both ends of the spectrum. I have seen persons who have come to the office seeking medical legal recourse, and on further questioning and objective testing, these persons either one had respiratory illnesses before, it may have been made worse on exposure, and two, you also have some persons who actually do not have any objective evidence of having significant respiratory diseases. From the workplace, though, it can be quite expensive, and the various industries need to provide appropriate education for the employees, as well as the appropriate PPEs, whether it is annual health checks and environmental control within the industry or within the plant. They are expensive to treat, and as I said, many of them are irreversible. So you're looking at treatments, rehab, and in some cases compensation, which is loss of both funds for the employee as well as loss of productivity, and in terms of the industry, their loss of income at the industry level and profit margins. Employment-based risk factors, you have to look at the size of the business, what region it is, what age of employees are most at risk, adherence to both local and international standards and regulations, prohibition of risky behavior within the workplace, including smoking, and the reduction of exposure, and as I mentioned, education of these employees. These are some of the substances that are seen in certain industries that are related to lung cancer. And when you look at the various dusts and the chemicals and the conditions that may arise because of them. So I will make the presentation available for you to look at, but just to underscore that there are a number of areas and a number of substances that are related to various respiratory disorders due to occupational exposure. There may be long-term disability. Many of these workers face permanent lung damage and loss of livelihood. It will put a strain on the healthcare system as these conditions require ongoing care. Some patients require oxygen therapy and, of course, the medication. And in other regions and countries, lung transplantation. And of course, there are the social inequities where workers in low-income, high-risk jobs who are often not provided with the appropriate protective equipment, as well as the education, these persons are disproportionately affected. When we look at prevention, reduction of exposure, screening to determine which persons may be at increased risk, which persons may have conditions such as atopy and other genetic factors that put them at risk. Persons need to be educated regarding the risks working within the environment and be provided with appropriate protective equipment, and ongoing screening needs to be taking place. So there's primary prevention and secondary prevention. So the primary prevention would be the workplace controls, providing proper ventilation, and in some instances, substitution for safer materials where appropriate. The personal protective equipment must be provided and they must be worn, and therefore regulatory policies are important. And as I mentioned, the secondary prevention would be screening and surveillance, regular lung function testing for at-risk workers. We have industries within Jamaica that if they are to participate with international trade, actually, they have to show that they are taking occupational health of their employees seriously and have to show where they are having some of these tests done on an annual or at least a periodic basis for them to be able to participate on the international markets. And we need to be looking at more industries and making sure that they are adhering to regulatory policies and guidelines. So tertiary prevention is once it is discovered, that medical care and rehab, and of course compensation, which is a vexing area for many persons to be looking at, but it needs to be provided once it is that these workers have been affected and it has been shown to be due to occupational exposure, with there being little regard in terms of the employers. Persons need to be taken care of. So awareness of occupational exposure is important. Some employees are not even okay with the fact that their industry may cause harm. So there needs to be, from the get-go, awareness and education. And reduction of exposure is a key to prevention. I know it's been long. We should be wrapping up. I hope you guys are still with me. We're looking at some emerging respiratory diseases and their public health significance. I mean, we just went through COVID-19, which began in December 2019. And by March, we had our first case here in Jamaica. It affected millions globally. I mean, there is nothing like this that any one of us had ever seen. It had a significant impact on the respiratory system. Many persons would have developed COVID-19 pneumonia, even acute respiratory distress syndrome, for which the mortality is very high. And even after the acute infection, you have long-lasting respiratory issues, as is seen with the diagnosis of long COVID. So the response, we saw an unprecedented vaccine development and global vaccine campaigns. That discussion we can have at another meeting, whether or not what was done appropriately and how effective it was. And looking at the emerging strains that despite vaccination were still emerging. Looking at another one, influenza, the H1N1 influenza emerged in 2009 and caused a global pandemic at the time. Although it was less deadly than other pandemics, it caused significant morbidity, and it affected primarily the young adults and children. Again, vaccines were developed quickly and global health efforts were successful in managing the disease, although it remained a public health challenge. Then there's a Middle East respiratory syndrome. This is another coronavirus. This was seen in 2012 in Saudi Arabia. It has a high mortality rate, about 35%, associated with severe respiratory symptoms. There was no global pandemic, but it did raise the awareness about coronaviruses and highlighted the importance of zoonotic disease surveillance, as most cases were linked to camel exposure. Then there is the SARS-CoV, which was emerged first in China and then caused a severe outbreak of respiratory illnesses. The outbreak was quickly contained through strict quarantine measures and travel restrictions, but the fatality rate was quite high, around 10%. RSV, as I mentioned, has become more prevalent in recent times. It is not new, but there's a growing impact on young children and elderly adults. It causes a bronchiolitis and pneumonia. It may be seasonal and is a major cause of hospitalization during winter or colder months. Global efforts have focused on detection and vaccination, both for infants and adults at risk. We have the novel influenza strains, such as H7N9 and H10N8, which cause severe respiratory illness and mortality rates tend to be high. Again, the development of vaccines have been critical in preventing outbreaks, and the H7N9 cases have largely been contained. So that was a glance at some of what is out there, what we're looking at. Emerging respiratory diseases are a constant public health threat, driven by novel pathogens or pathogens that are changing in form and in structure. We have changing environments and increased human-animal interactions, whether intentional or not. And as such, vigilance, surveillance, a rapid response, and a global cooperation are essential to mitigate against their impact and protect global health. But even with all of that being said, we have to recognize the country-to-country disparities, region-to-region disparities, and even within a country, the social group disparities that put other countries, other regions, and other persons at greater risk. So just to mention public health prevention strategies, we would have looked at these before, but there are the vaccination programs. We know that vaccines got a beating during COVID-19, but that being said, even if there was some mismanagement, vaccines still have a role, at least as far as I am concerned, in helping to manage and prevent a number of respiratory conditions. Tobacco control, we need teeth in our laws and greater vigilance and surveillance. And we need to really push this agenda in terms of at the government level, in terms of the law and our separation as it stands from industries that participate in the distribution and marketing of tobacco. Air quality improvement, cannot say too much about this. And again, health education from all levels coming up. Importance of hand hygiene, importance of how to sneeze, the sneezing hygiene and coughing, mask wearing where appropriate, and healthy lifestyles, looking at diet and exercise. Secondary prevention, which is to catch and treat early. Screening programs for early detection of conditions such as tuberculosis, regular lung functions for persons at risk of COPD, mentioned also screening for lung cancer in the appropriate persons. So these persons may not have symptoms. We want to catch the condition early and treat early. There needs to be prompt treatment, prompt investigation, and once a diagnosis is made, the appropriate treatment for the satisfactory duration. Tertiary prevention would include managing the disease to prevent worsening, as well as in terms of communicable conditions to prevent its transmission. So chronic disease management would include pulmonary rehab programs. So HIPAA are great, again, for the community-based programs that we're hearing about. Long-term oxygen therapy for advanced lung diseases, which I will tell you, oxygen therapy is expensive. And so because of this, many persons, many patients will say, Doc, I only take it like for 2 hours for the day. Because whether it is they're purchasing the cylinders or using oxygen concentrators, many of which are electrically driven, it costs a lot of money. When the recommendation for persons who require oxygen therapy, long-term oxygen therapy, is that it's not 1 or 2 hours per day, but at least 16 hours for the day. Patient education, teaching self-management skills, inhaler use. All of my patients who I see for asthma and COPD who are on an inhaler have to show me how they use the inhaler. I don't care if you're 2 or 202, or if you've had asthma for 200 years, I need to see how the inhaler is used. And the reality is that while 60% and more of our patients do not use an inhaler appropriately, so too do many of our health professionals not know how to use an inhaler. And not to beat yourself up, because the reality is that many times we're just not taught. And the number of inhalers and the different devices have been changing over the years. Policy and community level interventions, legislation, looking at laws and having teeth to these laws, clean air standards and vaccination mandates, global health programs, such as the WHO's NTB strategy that we have signed up to, but we need to be living and to be practicing. It's not just good to just sign a form or sign a treaty, but we need to actually then actively put the measures in place to have to treat, to detect, and to meet up to our goals and guidelines. Pandemic preparedness, I mean, COVID-19 taught us a very harsh lesson, treated us badly, but we should now be better prepared. And the big question is, are we? Are we any better off pre-COVID than we are post-COVID? We have heard authorities say that it's just a matter of time before another pandemic. I certainly would like to live a long, healthy life, and I don't want to see another one. But if that is the case, are we prepared? And it doesn't even have to be a pandemic, just an outbreak. Are we prepared? I know we've gone over time now. Let me see what this is. This is just a quick case study looking at the public health significance. COVID-19, well, we know it was caused by SARS-CoV. We know the transmission was primarily through respiratory droplets. and the impact it had on the lungs, causing severe pneumonia, acute respiratory distress syndrome, and death in many cases. Over 760 million people worldwide as of 2025. And we know that this is an underestimate, with over 7 million people having died. Respiratory failure and complications were among the leading cause of death, and we know our health systems were overwhelmed. This was an unprecedented strain. We have never seen anything like this before. There's a shortage of not just ICU beds, but hospital beds, medical staff. We had medical staff who resigned just because of how overwhelmed and how difficult it was. It led to massive healthcare costs, significant reduction in workforce productivity, and it disrupted economies worldwide. And the long-term costs are still ongoing, and we see persons with long COVID still, and post-COVID lung damage and long COVID are in some cases still unfolding. Older adults and persons with chronic respiratory conditions had higher mortality rates. And again, those persons in lower income communities were more vulnerable than others. People in regions with air pollution exhibited poor outcomes, such as those in parts of Asia and Europe, due to pre-existing lung damage. The vaccines were developed, mass vaccination programs were launched. So this was one of the global response, but as I said, this was a disproportionate response on accessibility and availability of vaccines. You had big countries such as the US and Canada that were actually holding on to vaccines. And it was when these vaccines were becoming out, some of them near expired, outdated, that they began to turn them out to other countries that were clamoring for vaccines. There were the non-pharmaceutical interventions, the lockdowns, as painful as they were, physical distancing and mask wearing, and then health campaigns. Public health initiatives such as the COVAX, which tried to ensure equitable vaccine distribution, particularly for low and middle income countries. So we did have some programs coming out, and we should be better prepared in the event of another pandemic or even outbreak. And it also highlighted what we can do and the technology that we have available to us, because we didn't know that we could meet without having face-to-face meetings. Now it is primarily Zoom. As a matter of fact, some persons, if called to a face-to-face meeting, are more upset because a Zoom meeting offers you greater flexibility. Telehealth became a reality, right? And we do recognize that with all of this, that while we focused on COVID-19, a number of the conditions would have suffered in terms of accessibility to medications. We need to look at all of this. What has COVID-19 taught us? Do we need to have somebody physically come with a prescription script now to get medication? No. Now we have WhatsApp. Even NHS has WhatsApp prescriptions, drop off prescriptions. They used to actually deliver medication to patients. So the COVID-19 pandemic, while painful, has taught us that we need not practice the way we did. It has also underscored that we recognize, having put all of our attention on COVID-19, that after the COVID waves and once the numbers started to decrease, we actually saw an uptick in admissions and an uptick in deaths of other conditions. So COVID-19 underscores the critical importance of respiratory diseases in public health. It caused not just immense morbidity and mortality, it exposed the vulnerabilities, social inequities, and the need for robust prevention. So in concluding, respiratory diseases are a major public health challenge. Prevention and early intervention are key. Collaborative action is needed at every level. Thank you. And I want to thank those who have stuck with it. And again, my apology for the late start. Any further questions or comments?
I just had one comment.
Go ahead.
And it was regarding the use of inhalers. And I'm not sure how much we can reiterate how important it is. Had a gentleman who was probably in his 70s, and he just kept coming to the health center. He was already going to pulmonology clinic. He was on Spiriva, and I couldn't understand why this man was so sick all the time and had to be coming to the health center to be nebulized. And one day I said to him, I said, just show me what you do with the inhaler at home. And he says, boy, doc, I don't understand this something, I don't see anything coming out of it. Something must be wrong with it. And I said to him, no, this inhaler is not like the ones you are used to. You're not going to see anything when you spray it in the air. And so that day I said to him, okay, and I showed him how to use it. Fast forward, I'm there a month, I don't see this gentleman. 2 months, I don't see this gentleman. We're going into the 3rd month, his daughter comes to the health center. And I'm like, should I ask her about him or shouldn't I ask her about him? But if he has died, and then I'm going to trigger her and all these things, that's what is going on in my mind. And then I say, let me just ask her, how he's doing. I haven't seen him, what is happening with him. And she says, he's been well since the last time you showed him how to use the inhaler. And because of that, it's like, now when I see a patient, every patient, regardless of which inhaler they have, something says to me, ask, show me, take it out. You're here today. I've nebulized you, but still take out your inhaler. Did you use it today? Show me what you're doing. Because just one conversation with this gentleman who was already on Spiriva but living in the health center.
That is so true. And part of that actually for our asthma care is that we need to take the time. We need to learn how to use the various devices. And just to say that not every device is suitable for each patient because different devices require different, what we call inspiratory muscle strength. And if you have someone who is exceptionally weak, very weak, then you have to find the appropriate therapy. And we need to really take the time. I'll tell you, and you can't judge people, or you should not judge people. I remember I had a patient who higher level educated woman, living in the middle and higher socioeconomic brackets, well-paying job, etc. And it is not to assume that somebody who is in a lower bracket, who may be uneducated or does a primary level education, although the studies do show that such persons have even greater difficulty. But I said to this lady, please show me how you use your inhaler. And she took the inhaler, she shook it, she put it at one nostril and pressed and inhaled, and she put it at the other nostril. And I opened my eyes widely, and I said to her, who showed you to do that? And she said, nobody, doc. But see, the instruction says 2 inhalations daily. And where do you inhale from? You know, right? So it is not to assume, and that is why every person needs to go through it. We need to take the time. And you are so correct, Nicola. Once you have somebody who has been taught how to use the inhaler appropriately, their office visits, their hospital visits invariably will be reduced. So thank you for that. I just want to say
that. Oh, continue that.
No, I was just about to say a big area for me as well would be spacers and nebulizers. I've been practicing pulmonary medicine for quite a while. And before that, I was even doing internal medicine. And I don't think for my years of doing pulmonary medicine that I have recommended that somebody get a nebulizer. Right now, I can think of one patient. So let me just give an estimate and say 2. And that is not an underestimate because the majority of persons do not need a nebulizer. Left up to me, every nebulizing company, except for those that provide equipment to the health facilities, but all of those home nebulizers, the majority of them will be out of pocket because with the use of a spacer, a patient can get effective therapy at effective doses. And if it is not working, that is the time, and that patient needs to go to hospital. If it is a child, we use a mask because that child wouldn't be able to inhale through the mouth. Or an elderly person, you may use a mask that is fitted or show the person how to make a spacer. But too many people sit at home nebulizing themselves, and then when they get to the emergency room, sometimes it is a little too late. Thank you.
Got one question, Miss. I know I was just adding to what Nicole said that actually, no, with your patient, I actually found another colleague of mine told me that story, and I was like, you're lying. No patient is going to do that, but then it was actually true, and then you just mentioned it as well that actually more persons are probably out there doing that same thing, as in using the nostrils. But my question was to ask for clarity in terms of asthma. Going back to asthma, you said for the diagnosis, maybe I missed it, that you also need spirometry, or it's just a clinical diagnosis. I'm not sure if I had missed it.
So the international guidelines that many persons adhere to would state that to make the diagnosis of asthma, the patient should have spirometry, lung function testing, because sometimes even after spirometry, we do further testing. However, spirometry is not widely available. So we really need to look at how the diagnosis is going to be made, and is it a case that's why no matter how high tech we become, we need to sit and speak to our patients and get a history from our patients. And if we really think that this may be asthma, maybe give a trial of a medication, look at what the person reports as triggers. I do agree that in some instances it may be a little bit more tricky. In those cases, refer the patient to a physician or to an institution or a facility that is accustomed to seeing patients who have asthma. They're accustomed to seeing patients who may have more challenging diagnosis, but it's not appropriate to have someone sitting there and not offer help. And if you're unable to readily identify and manage what's going on, refer. But spirometry internationally is considered required to make the diagnosis, the definitive, let me use that word, the definitive diagnosis of asthma, and should be used to follow the patient with asthma.
Okay, and the last follow-up to that, does National Chest offer pulmonary function tests? Because I sent a patient there and they came back saying that they were told, no, it's not offered there.
So we offer limited pulmonary function tests. If a patient comes to us just for pulmonary function tests, we want to tell the patient no. If the patient is in our clinic at National Chest Hospital, so we offer it for our patients. And the reason is that we have a spirometer. We don't have all lung functions available to us. We have a spirometer, and the persons who are doing the spirometric test, it is either a nurse or one of the doctors. And recently we've had one of the administrative assistants who has been trained to do it. Is she still an administrative assistant? Yes, she is. So we don't have anybody dedicated to doing lung function tests. So we can't open that door and have external persons coming for lung function tests. We're not there yet.
Okay, understood. Thank you. So there is a gap then if we were to follow international guidelines, because I have to try send them privately and then how that goes.
There's also the use of a peak flow meter. So peak flows meters can also be used. And you're looking for a variation in peak flow. So peak flow meters are relatively inexpensive. They may not be widely available, but they can be had, and you can use a peak flow meter as to look at variability in terms of their efforts and what happens. Sometimes we even use a peak flow meter when we're looking at occupational risks. So you do your peak flow meter at home, you do it at hospital. We use a peak flow meter in managing persons with asthma. Listen, you have your peak flow meter when your levels drop to a certain number, this is what they're supposed to do. And I will say in my private practice, I do peak flows pretty often. I'll have patients that come in and for a number of reasons. Sometimes it's affordability. Sometimes it's no doc. I can't manage going into that thing. I don't know if any of you have ever done spirometry, but it does take a bit of effort. And some people just don't have the time or whatever the reasons. But or sometimes I just need a quick assessment. So I'll have a peak flow meter and I can use that to follow the person. So I have a patient, for example, who comes in and based upon their gender, age, height, say for example, their peak flow is supposed to be 350 liters per minute. And they come in and they think they're quite fine. It may come back at 280, 270. So then, you treat them, alter management, and you take them back in. So when they come back, you repeat the test and you see what it is doing. And many of them will ask, so what it was the last time? So I make sure it's in my notes. Another thing that I use my peak flow meter to do is the person may not be able to achieve their predicted value, but their best effort is at 250 liters. So I can recheck when they return to see, well, are you still at 250? Are you less than 250? Or has the treatment made a difference, and are you better than the 250? So it doesn't substitute for the spirometer, but it can be used in many instances to assist, because we still get good information from a peak flow. Again, you need to educate your patient on how to do it properly.
Okay, thank you, Miss. That's it from me.
Okay, thank you. Any other questions?
Good night, Dr. Baker. I know it's late, so I'm just going to be quick with my question. Just circling back to the whole lobbying and primary prevention that was mentioned in the chat as well. With the construction going on across Kingston and considering that some of this construction, for example, are within school zones, for example, St. Paul's, and the work that's done on Wellington, that area there. There's just so much dust, right? And the question I continue to ask is, how is this affecting the school population? And has anybody ever actually done any sort of assessment to see? So from where you stand, have there been any increased reports of the respiratory illnesses or exacerbation of asthma in the pediatric population since the construction, or no?
I will have to get back to you on that, and I'll tell you why. I rarely see kids. Not that I have anything against them, it's just that I'm not a pediatric pulmonologist. The kids, they have even other conditions that are peculiar to them. So they have pulmonologists for themselves. I will say a few teenagers, but the majority of my patients are adult patients. But that's a very, 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 very valid question. And it definitely is something that we should inquire about. And it is something that we should look at. Many times, one person is looking at the next or and nobody is or necessarily stepping forward or having the person is who is going to bail the cat, or we need the data. But that is a very valid question, and I am going to inquire of our pediatricians and pediatric pulmonologists if they are seeing more cases. I know I've seen more cases in the adults when construction is taking place that they do present. Do I have the numbers? No, but you do see them.
All right, thank you so much. Because I'm just thinking that this could also be a point of lobbying, so that since we're for the country's progress and economic development, they're going to be pushing more construction. We also need to balance this with having environmental protocols in place to control the dust and so forth. I know when you're doing it with certain organizations or so on, it's actually part of the protocols and procedures, but outside of that, it might not be. And so that's probably something that, as physicians, I'm not sure if there's a pulmonology group that could lobby and put that on the board.
So that is part of one. I agree with you. One of the issues we've had is who is going to lobby for what, or who is going to take the lead. Because lobbying is a 28 per hour day factor, and having opened the door, we need to start to make the inquiries, and then we need to decide, so who is going to take that mantle? Because it is important. Do we look at the pulmonologists? And I'm not excusing ourselves from it. Do we look at the pulmonologists? Do we look at the school groups? Do we look at the school PTAs and principals? And then have support coming from the physicians and the pulmonologists. And I say this because I'm just looking to say that right now I'm fighting tobacco and tobacco smoke. And you have so many different fights taking place. And when you have effectively 4 of us, 5 of us, it's difficult to take on every one thing. But that being said, it still does not mean that we should not be a part of it. So we may not take the lead, but we need to be a part of it. And we need to be inclusive in terms of opening the eyes of other persons. Because I never thought of that, to tell you the truth, about the kids. But it is a very valid point. So the question is now, having gotten that information, what do I do with it? I go to my pediatric colleagues and I say, this is something that needs to be looked at. And then we join the various groups lobbying. Lobbying requires a different level of fearlessness, I should say, in some regards. I remember listening to a group on the radio once talking about the same construction, and one of the government agencies saying that the loss of green space in Kingston, we still have a lot of green space in Kingston, and that the amount of construction going up was not a problem. And I'm like, what? How can you as a government agency really come up? Well, in my regard, I don't have and say something like that. So it is not for people who are easily discouraged. And so we need it at all levels. We need it in this instance, the schools, the PTAs, the physicians, public health persons, and other NGOs that have an interest. But thank you for that.
Thank you, Dr. Baker. Thanks.
Okay. Well, again, let me thank all of you for sticking with it. And the other thing we need to look at is this traffic in this country, in this city. It is getting, which I gather the construction is making it even worse. When they come out and say, "Oh, it's the rain," it's not the rain. It's the various
Unregulated construction, doc.
Exactly.
Unregulated, uninhibited. It's just oh my gosh.
I mean, I'm not delaying any of this, but I tell you today at 4 minutes past 4, I was at Immaculate's front gate. I did not get to Manor Park. I don't know for those people who know where Immaculate is or where Manor Park is, you can walk it easily. I did not get to Manor Park until nearly 5 o'clock. All right. So our apologies again, and yes, we all need to be vigilant. That being said, let me wish you a good night, and I will make the presentation available. Thank you.
Thank you.
Good night. Thank you.
Thank you, Doc. Good night.
Good night.